Hello, everyone, and a warm welcome from here from the studio. Uh, so, the next edition of the SIP of Science meeting, and it's my great pleasure to have Professor Sheila Myatra with us from India. I know Sheila for long, long years, and I was quite surprised when she announced her topic, to be honest, because one of the most cited articles of yours, Sheila, is a tidal volume challenge, right? Paper, and which is a landmark paper in the field. But this time we're going to talk about hemodynamic instability after securing the airway after endotracheal intubation. And if I'm not mistaken, you will focus in your talk on that consensus paper that was recently published in Intensive Care Medicine, which is the highest ranking journal of our specialty. So it is my great pleasure to hand over the stage to you, Sheila. So please share your screen, and we are really looking forward to your lecture.
Thank you so much, Professor Molnar, for that kind introduction. And it's indeed a great honor and pleasure for me here to be a part of this very innovative series called SIP of Science. And I'm really happy to be here, and I love to teach. And I'm happy to hear that it's an anesthesiology and a critical care audience because this talk is very relevant. It's on airway management. And as Zolt said, it's a very provocative title. The tube went in, but my patient still collapsed, and how we can manage that physiologically difficult airway. So I'm Sheila Myatra. I'm professor of critical care, working at the Tata Memorial Hospital in Mumbai, India. And I have no relevant disclosures for this presentation, no conflict of interest. So I'll start with a case scenario. 57-year-old male, acute hypoxemic respiratory failure in the ICU, and he needs tracheal intubation for worsening hypoxia. He's deleterious, uncooperative, he's on BiPAP, 100% FiO2. The saturation is 88 to 92 with a respiratory rate in the 40s. Airway examination, of course, is not possible in this situation. Heart rate is 120, blood pressure is 140 by 78. Fasting status is unknown, and the labs are grossly within normal limits. We give him etomidate and suxamethonium, and of course, a rapid sequence intubation because we don't know about his fasting status. By default, all critically ill patients undergo a rapid sequence intubation. VL guided intubation was done. It's a grade 1 view. Endotracheal tube passes through the cords. Waveform capnography is used for confirmation, and we're really good to go. And we're so happy about this because everything seems good and it's confirmed that the tube is in. What next? The patient's blood pressure drops to 80 by 40. End-tidal CO2 drops from 30 to 15. You give a push of phenylephrine, a patient becomes pulseless, and you start CPR. This is quite dramatic. Not often do you see a patient receiving CPR, but I'm sure you've seen this kind of situation immediately after tracheal intubation in the critically ill patients. Now, what this patient has is called a physiologically difficult airway, and this was first described by Jared Mosier and John Sackles way back in 2015 when they talked about the physiologically difficult airway for the first time. Now, all along, we are obsessed with the anatomy. We're obsessed with getting the tube inside, and we talk about difficult airway in the context of technically getting the tube inside. But we have to think beyond this because there is an entity called the physiologically difficult airway. And what we mean is that the physiological or pathophysiological derangements that increase the risk of complications during tracheal intubation and transition to positive pressure ventilation. Now, John Sackles described this only as pathophysiological alterations, but over time, and this is actually an emerging definition, and we published this article in Current Opinion of Anesthesiology, and we said this is an emerging concept, and it's not only the pathophysiological alterations that you see in critical ill, but also other physiological alterations that you see in obstetric patients, in obese patients, perhaps also in children, which shorten their safe apnea time and increase the risk of complications during tracheal intubation and transition to positive pressure ventilation. So this was kind of an emerging concept, kind of sensitizing people that we need to think beyond the anatomically difficult airway. And recently, the paper that Professor Molnar was alluding to is this one that is published in Intensive Care Medicine. And this is titled Tracheal Intubation in the Critically Ill Adults with a Physiologically Difficult Airway. And this was an international Delphi that we did with global airway experts in critically ill, in tracheal intubation in critically ill adults. And we did a Delphi because there were many gray areas where we didn't have very robust evidence in the literature. So a good, robust Delphi study was conducted so that we have consensus on various interventions for tracheal intubation in critically ill patients, including the definition of physiologically difficult airway itself. I really urge you to read this paper. It was just published last month in Intensive Care Medicine. And we've given expert consensus statements that are summarized in these two tables. And it's a very useful takeaway. And most of my talk is going to be based on these consensus statements. So let's come to the definition and what was the consensus. So physiologically difficult airway is defined as one in which the patient's physiological and pathophysiological alterations increase the risk for complications during tracheal intubation and transition to positive pressure ventilation. Now, pathophysiological alterations, what are those? These are the ones that we commonly see in critically ill patients, like hypoxia, cardiovascular instability, right ventricular dysfunction, increased intracranial pressure, as well as physiological alterations that occur, such as obesity, pregnancy. All these constitute a physiologically difficult airway. And of course, the environmental and human factors also play an additional role. And most likely, you will encounter these patients in the emergency department and in the intensive care unit. So when we talk about a physiologically difficult airway, it involves the pathophysiological alterations like hypoxemia, cardiovascular instability, right ventricular dysfunction, increased intracranial pressure that you see in the critically ill, as well as the physiological alteration, because these also are associated with reduced FRC and increase the risk of complications due to the short apnea time. So this was the consensus definition that the expert panel came up with. Now, I'm sure you've all, seen this study, the Intube study that is very, very highly cited. This was published in JAMA, and I was very fortunate to work along with this group, and I was a co-PI of this paper along with Professor Vincenzo Risotto. And all along, we've looked at tracheal intubation practices in critically ill patients, either they're single center studies or, within one country. And this is the first time we looked at real world data across the globe, looking at what were the complications related to tracheal intubation and how were people intubating critically ill patients in the intensive care unit. And this was done across 29 countries. And, the ones that are contributing maximum data were from the countries of the two PIs, that's Italy and India. And as you can see, this was across 5 continents and close to 3,000 patients. Now, I'm just going to give you a snapshot of this study to make you understand the concept of the physiologically difficult airway. And this was an observational study. The primary outcome was looking at least one of the following events occurring within 30 minutes of tracheal intubation. So either hypoxia, cardiac arrest, or cardiovascular instability occurring within 30 minutes of tracheal intubation. Now, as was kind of expected, the primary complication rate was high, but how high? 45%. That means 1 in 2 patients in whom we do a tracheal intubation in the critically ill patient actually have a complication. And one would think it's severe hypoxia, that's the common complication. But the really interesting finding and an eye-opener from this study was that it's not the hypoxia, but cardiovascular instability that occurs in 42% of the patients. So again, almost 1 in 2 patients who are critically ill and who you intubate actually have hypotension or some kind of cardiovascular instability. And severe hypoxia occurred only in 93% of the patients. That perhaps over time, we've become better at peri-intubation oxygenation. Cardiac arrest was seen in about 3.1% of the patients. So this was a really new finding that actually the incidence is quite high. And this study had real-world data from both the developed world as well as the developing world, unlike previous studies that was only from the developing world. And one very interesting finding from this study was it was the first study that looked at mortality. It looked at 28-day mortality. Following the tracheal intubation, whether this complication had any correlation with mortality. And it's very interesting to see that if you had an overall complication or you have cardiovascular instability or cardiac arrest, this increased the risk of 28-day mortality. Now, that's a very important finding. It's the first study that's demonstrated that the complication that occurs just after tracheal intubation, hypotension, hypoxia, which you immediately correct and take care of and don't give that much importance to, actually has a bearing on the long-term outcome, 28-day mortality. So it's not something that we just need to treat, but perhaps we need to prevent this complication from occurring if we want to reduce the mortality of our patients in ICU, because this has a bearing on the 28-day mortality. So we have to take these complications that occur more seriously, and we have to look into how we can prevent these complications. So being an anesthesiologist, though I'm doing critical care, I do spend some time in the operating room. I still do about 20% of anesthetics. And so I'm in the perfect position to compare tracheal intubation in the operating room with tracheal intubation in the intensive care unit in the same period of time. And I often wonder that why are complications related to tracheal intubation in critically ill patients so high? We don't see such high complications in the operating room. And in my mind, there are three fundamental differences between tracheal intubation in the ICU and the operating room. One is the ICU environment related factors. Second is the operative factors. It's not the same experienced anesthesiologist doing tracheal intubation in the intensive care unit whose core competency is airway management. And the third most important factor is the patient itself. It's not the fasted, optimized patient who comes for surgery in the intensive care unit. And so if you look at the patient, and there's often an imbalance in critically ill patients between oxygen delivery and oxygen consumption. There are many factors like fever, sepsis, tachypnea, etc., that increase the oxygen consumption. And as you know, the delivery is already compromised because of the low cardiac output, anemia, lung disease, and various factors. So these patients already start with an imbalance between oxygen delivery and consumption. And I'm sure you've seen the Benimorph curves. And this has a time to desaturation on the x-axis and the saturation on the y-axis. And if you compare it with the normal patients, if you look at critically ill patients, they already start with a low FRC. They have high oxygen consumption. And these patients, compared to normal patients, rapidly desaturate after a rapid sequence intubation. So these patients already are at a disadvantage, and they have what we call, again, a physiologically difficult airway that increases the risk of hypoxia and other complications because of they start with this disadvantage. They already have this imbalance due to their critical illness. So that is why team preparation and human factor considerations are really, really important. And these were the consensus from the experts. And they said a checklist is very important. And though there is a randomized controlled trial coming from the Vanderbilt showing that whether you use a checklist or you don't use a checklist, it doesn't make any difference. But this study was criticized because it didn't look at physiological optimization. It just looked at various tools for tracheal intubation, but the physiological optimization was not part of their checklist. And I'll just give you an example. If your wife told you go to the supermarket and buy 20 items, it's more likely that if you make a list and you list all these items that you're going to come back with at least 20 of those items rather than randomly trying to. So it's a kind of common sense that a checklist will make a difference, especially in this high risk environment that we're working at, that itself increases the risk of complications. I cannot emphasize how important the team preparation are. And the recommendation was that the intubation team should consist of at least 3 healthcare workers. And next time you do a tracheal intubation, look at how many people there are around the bed. But in terms of the people who are the airway managers, there should be at least 2 airway operators, and one of them should be experienced in tracheal intubation. And this was also emphasized in the study from Professor Samir Jaber in intensive care medicine in the past, based on which they gave the recommendation for the intubation bundle that you should have 2 airway operators with one being experienced. And most important, the debriefing is very important post-procedure, irrespective of what the outcome is. I cannot emphasize how important training is. Training is paramount, especially in the intensive care unit where we have wide variation in the backgrounds from which the specialists come, the intensivists come. So training, and especially simulation-based training, is really, really important. And there was consensus for this. Now, performing the procedure, and I'm going to go about a little bit into how we should perform the procedure. And I'm going to give you the consensus recommendations by the expert panel as to how you should approach the airway, what medications you should use, what tool you should use, and what should be your immediate priorities, how you should ventilate, and finally, how you should monitor these patients. So let's look at airway assessment. Now, if you look at our patient, it was impossible to assess the airway. And these are not like patients who come for the surgeries and whom you can do a good airway assessment in the clinic. These patients are difficult to assess the airway often, and that's mostly because they are uncooperative, or sometimes you have very less time and you have an emergent tracheal intubation, you have to intubate them very rapidly and you won't have time, or they may be comatose and it may not be possible. But what the experts had a consensus on is that whenever possible, you should do an airway assessment and also counsel the patient that he's going to be intubated. And they recommended that you should use screening tools like the Makocha scoring system and the HIPS tool. And I'll tell you about the Makocha scoring system. Now, the Makocha scoring system, this is comes from France, from the group of Audrey de Jong, and it is the validated scoring system for tracheal intubation in critically ill patients to identify a difficult intubation. And it has a score of 12. And I like this score very much because it not only looks at anatomical factors, but it also looks at physiological factors. Factors related to pathology like coma and severe hypoxia itself gets 1 point. And it also looks at the experience of the operator. So if you're a non-anesthesiologist, you get 1 extra point for risk. So it not only looks at the physiological factors and the anatomical factors, but also the experience of the operator. And this score has been validated. It can be quickly done in the patient. So whenever you get an opportunity, try to use the Makocha scoring system in critically ill patients before tracheal intubation, and use this opportunity to use the scoring system. What we need to do is what we call a modified rapid sequence intubation. Now, when you call a modified rapid sequence intubation, it means that you titrate the administration and rapid onset of the sedative hypnotic drugs and the rapidly acting neuromuscular blockades. You can give gentle mask ventilation, should be considered in patients to prevent peri-intubation complications. So conventionally, we don't give gentle mask ventilation, but I'll talk about a study that has, increased our confidence to give gentle mask ventilation during rapid sequence intubation. Cricoid pressure, well, there was no consensus on whether we should or should not use, because the evidence and the literature is very controversial on that. But they said if you apply cricoid pressure, you should release it, especially if there's difficulty in visualizing the vocal cords during tracheal intubation. And there's no doubt about that it could be released when you have this kind of occurrence. Now, positioning is really important in critically ill patients. And whether you should give snipping position or what position or the health position, it's all controversial. But definitely there was consensus that you should give at least a 20-degree head elevation. So this is called the health position, the head elevated laryngoscopic position. And in this position, when you give this elevated position, why do we give this? Is because patients are more comfortable when they're propped up rather than when they're made to lie absolutely flat. When you see a patient who comes in acute hypoxemic respiratory failure, he's actually sitting up, leaning forward. And that's the position in which he's most comfortable. And we try to make them absolutely flat for tracheal intubation and pre-oxygenation. And the other important reason why you should keep them a little elevated is because in the flat position, the posterior portions of the lung, they become more prone to atelectasis and the collapse. And that is why it's better to keep them in a little propped up 20-degree elevated position, not only for pre-oxygenation, but also for tracheal intubation. And this is a good position called the health position. Now, what about pre-oxygenation? And this is a landmark trial that's published just this year in the NEJM, and it comes from, again, from the Vanderbilt University, where they compared non-invasive ventilation for pre-oxygenation versus conventional oxygen therapy. And one would wonder, why would you do that? Isn't it very obvious that non-invasive ventilation would be superior? But, well, there was no randomized controlled trial that head-on compared this. And they did it in about 1,300 patients. Non-invasive ventilation, that means, pressure support with a bit of PEEP for pre-oxygenation versus conventional oxygen therapy. That was the primary outcome, was hypoxia during intubation. And there was a significant difference between the two arms. And what they concluded was that among critically ill patients undergoing tracheal intubation, pre-oxygenation with NIV resulted in lower oxygen incidence of hypoxia during tracheal intubation and pre-oxygenation with the oxygen mask. Now, what about non-invasive ventilation with high-flow nasal oxygen? So Florali 2 study is the first study that is compared head-on non-invasive ventilation with high-flow nasal oxygen. And this was a multi-center study that was done in France, where they looked at the primary endpoint was saturation going below 80%. And interesting that if you look at the primary outcome, there was no difference between using non-invasive ventilation and high-flow nasal oxygen in terms of the primary outcome. However, in the subgroup of patients who had PaO2, FiO2 ratio less than 200, non-invasive ventilation was superior. So perhaps because of more definitive delivery of PEEP, and so definitely in the moderate to severe hypoxia, non-invasive ventilation, pre-oxygenation with non-invasive ventilation is superior to using high-flow nasal oxygen. And then after, we have this other trial that again comes from the Vanderbilt group, which was published in NEJM. And this was the bag mask ventilation during tracheal intubation in critically ill patient. Now, this raised a lot of controversy because conventionally, during RSI, which is done as by default in critically ill patients for tracheal intubation, we don't use bag mask ventilation. And that, why is this? And this is because of the risk of aspiration. Critically ill patients are considered as full stomach by default, and we do an RSI. And this is because of the gastroparesis of critical illness itself. They may be full stomach, they may be diabetic, whatever. So by default, we always do a rapid sequence intubation. Nevertheless, on one side, there is this perceived risk of aspiration, whereas on the other side, they are at a high risk of desaturation because of the physiologically difficult airway, the ARDS, the pneumonia. So we have to strike a balance between the two, and you can't always say no ventilation. So what this group did is they did a randomized controlled trial. In one group, they gave gentle mask ventilation, and the other group, they gave the conventional RSI. And what did they found? Obviously, in the group that they gave, gentle mask ventilation during the apnea period, the lowest oxygen saturation, there were less incidents, and it was a significant difference between the two groups. The study was quite criticized because it was not powered for aspiration. There was no increased aspiration in this group. Nevertheless, this study definitely gives us confidence that in those patients who are at a high risk for desaturation, gentle mask ventilation will definitely do some good for the patient. So we can use gentle mask ventilation during the RSI. The other study which I want to talk to you about is delayed sequence intubation. Now we talk about rapid sequence intubation. What is delayed sequence intubation? Now this was a term that was introduced by Scott Weingart, who comes from emergency department. And this is basically those patients who come very rowdy and hypoxic, who need intubation the most, but it's really difficult to pre-oxygenate, who need pre-oxygenation, the most, but it's really difficult to pre-oxygenate them because they're thrashing around, they're hypoxic, and you just can't pre-oxygenate them. And that's why you just knock them off and try to intubate them, and you don't give them adequate pre-oxygenation. So delayed sequence intubation involves giving small sedative doses of ketamine to these patients. So you calm them down. Ketamine does not produce any respiratory depression. You calm them down so that you can pre-oxygenate them well and give enough time. And then after adequate pre-oxygenation, you can either do a rapid sequence intubation. In fact, it's very interesting because now I've started doing this technique a lot. And it's commonly practiced in the emergency department, not so much in critically ill patients, but many of my patients actually don't need intubation. When you see them at that time, very, rowdy, hypoxic, you actually think I should quickly intubate this patient, but you can actually avoid an intubation in some patients. Now, after this term was described, no one had prospectively studied it in a randomized controlled trial. And the first randomized controlled trial comparing peri-intubation, delayed sequence intubation versus rapid sequence intubation comes from India, from one of my colleagues. And this was an RCT. And they looked at the oxygen saturation at various time points when you conducted a rapid sequence intubation. And if you can see at all the time points, baseline, even 1 minute after induction, there was a significantly better oxygenation in those patients in whom a delayed sequence intubation was performed. So delayed sequence intubation can be used to, adequately pre-oxygenate these kind of patients. So coming to oxygenation and respiratory optimization, the guideline, the consensus was that pre-oxygenate with non-invasive, especially when the patients are at a high risk for desaturation. Apneic oxygenation should be continued during attempts at intubation. Gentle, careful mask ventilation, especially in those patients who are at a high risk. And in patients who are difficult to pre-oxygenate, who are rowdy and hypoxic, we should use a delayed sequence intubation using sub-anesthetic doses of drugs like ketamine. Now I'll move to cardiovascular collapse, right? So that's about respiratory optimization. Now our patient had, a cardiac arrest. Some of these patients just have hypotension. Now I've often wondered, and this is a graphic from one of my articles in Anesthesia and Critical Care Medicine, that why do patients have hypotension following tracheal intubation? Critically ill patient. It doesn't happen so much in the operating room. Now there are many contributing factors. If you look at there's the critical illness itself, sepsis, hypovolemia, etc. The drugs that we use for tracheal intubation, propofol, benzodiazepines. A very important factor is the loss of the sympathetic drive. So a lot of times what happens is that you see that, the patient comes in acute hypoxic respiratory failure, his heart rate is high, his blood pressure is high. And this is because of the sympathetic drive. And this gives you a false sense of security, and you give propofol to this patient. But when you anesthetize this patient has precipitous fall in blood pressure when the sympathetic drive is lost. The other factor that causes hypotension is the positive pressure ventilation. These patients are often hypovolemic, and then after intubation, You give positive pressure, it decreases the venous return, further decreases the cardiac output, and then you have precipitous fall in blood pressure. So there are many contributing factors that cause cardiovascular collapse in tracheal intubation in these patients. Now, an important factor are the drugs used, and we have been cognizant of the fact that there is hypotension after tracheal intubation critically ill. So we have been using drugs like ketamine and etomidate, which are more cardiostable in comparison to propofol. So this was also the consensus recommendation. And one recommendation was against the use of standard induction doses of propofol. Anesthesiologists actually in the Intube study were the greatest offenders because they always use propofol as which we use in the operating room as an extension in the critically ill patients because they love to use the drugs, whereas the emergency department and the physicians did not use so much propofol. They use either ketamine or etomidate. And the consensus was that ketamine is safe to use, and the muscle relaxant that you could use for RSI is either suxamethonium or rocuronium. And suxamethonium, of course, should be avoided in certain situations where there is a clear contraindication for the use of these medications. Now, whether you should use ketamine or etomidate, the consensus was that you could use either. And I'll take you to this Bayesian meta-analysis that was recently conducted by Yuki Kotani and his group. And here they looked at ketamine versus etomidate as an induction agent for tracheal intubation. And the primary outcome was mortality. And in this Bayesian analysis, they found a moderate probability that induction with ketamine compared to etomidate for tracheal intubation was associated with improved survival in critically ill patients. But of course, for all other endpoints, there was really no difference. So the consensus was that use either ketamine or etomidate as a default, but don't use propofol in these patients. Now, a very interesting thing I want to show you is that the Intube study, which showed that 42% of the patient had cardiovascular collapse. What we did is we took all those 42% patients who had cardiovascular collapse, and we did a multivariate analysis to see what were the factors associated with the cardiovascular collapse. And we published this in the Blue Journal as a sub-study of the Intube study. And interestingly, we found that the use of propofol was an independent risk factor for and a modifiable intervention significantly associated with cardiovascular collapse. And as I mentioned, the majority of the people in the Intube study who used propofol were anesthesiologists, were the bigger offenders. And the important message was for this study was that irrespective of the starting blood pressure, propofol independently transitioned into hypotension, and we should avoid using propofol as far as possible in critically ill patients. Now, the other intervention that is often followed is a fluid bolus, right? We are cognizant of the fact that there's hypotension. So a lot of people give a fluid bolus prior to tracheal intubation to avoid this hypotension. But this had never been studied prospectively in a randomized controlled trial. And this was done by the Vanderbilt group. They did an RCT comparing giving a fluid bolus prior to tracheal intubation versus no fluid bolus. And they looked at the impact on, cardiovascular collapse. And interestingly, something that we believe prevents hypotension had no impact on the cardiovascular collapse, whether you gave a fluid bolus or you did not give a fluid bolus. But in the same study, in the subgroup of patients who had received positive pressure ventilation, there was a difference in the incidence there was lesser cardiovascular collapse when fluid was given. And this subgroup was those who got positive pressure ventilation. That means who got NIV for pre-oxygenation or who got gentle mask ventilation during RSI. So they went ahead and did a second study, and this was called the PREPARE study by the same group. And what they did in one group of patients, they gave, all those patients who received positive pressure ventilation, they gave them a fluid bolus. And in the other group, they did not give a fluid bolus. And interestingly, again, there was no difference in the incidence of the cardiovascular collapse. So 2 studies showing no difference. Of course, there was some limitation in the study. In the interest of time, I won't go on to this. But, if you look at it objectively, the incidence of hypotension is 42%. So the incidence is really high. And what do we give for that? Fluid bolus before tracheal intubation. But both the studies have showed that fluid bolus doesn't seem to be making any difference. So perhaps there is a role for giving a low dose of vasopressor prior to intubation to prevent the cardiovascular collapse, because we can't just treat it, we have to do something to prevent it. And now there are 2 trials underway. One is the fluid trial that is comparing a fluid bolus versus a low dose of vasopressor, and we're talking about norepinephrine. This is a study that has just been completed in my unit, and we're analyzing the results, and this is called the fluid trial. And the second study is being done by European Society of Intensive Care Medicine. This is the prevention trial. I'm also a part of this, and this is a multi-center trial where we're comparing a low dose of noradrenaline versus usual care. So the results of this study, perhaps next year we'll have the answer whether there is a role of giving a low dose of vasopressor, and of course this is given from a peripheral line because not all patients have a central line. We start it 10 minutes before tracheal intubation and continue it until 5 minutes after tracheal intubation. And perhaps this low dose may have some role in preventing rather than just using norepinephrine to treat these patients. And of course, the consensus was also for hemodynamic optimization and monitoring throughout, because you see these fluctuations in the hemodynamics. And optimization is very important. We recommended that you can either use vasopressors or fluids, because the results of the studies will tell us the answer whether vasopressors have some role. And ultrasound has a very important role in assessing these patients, because you can look at the patients who are fluid responders. You can look at the cardiovascular status. So ultrasound has in the peri-procedural period, the point of care ultrasound has a huge role to play in these patients. Now, moving quickly to the tools for tracheal intubation, and we all use a video laryngoscope, and the recommendation was that a video laryngoscope should be available in every ICU, and with all the intensivists trained to use it. And video laryngoscope should be routinely used as a first attempt, of course, if it's available and if it's feasible. And in addition to this, we should use a stylet or a bougie routinely during the first attempt at intubation. Now, video laryngoscopy in the Intube study, it was very interesting. We published a sub-study in the BJA. Now, when we looked at those patients who received video laryngoscopy, and that was only a very small percent, only 17% patients, received a video laryngoscopy. And that was a very surprise finding, because this was data from even the developed world. So the use of video laryngoscopy was very low in the Intube study in critically ill patients. And we actually found that, even though it was 17%, this was 500 patients. And when we analyzed the data, it actually showed that first pass intubation success was higher in patients in whom the Intube study, in patients in whom the VL was used. And this was a very interesting study, because this is the first finding, a study that showed that video laryngoscope actually reduces, increases first pass success, because the data in ICU had been very controversial, and many studies did not show any difference in first pass intubation success. And these findings supported systematic adoption of video laryngoscopy for intubation in the critically ill. And of course, we have this randomized controlled trial that was published in NEJM that showed VL versus DL. There was a significant clear separation between patients who received video laryngoscopy for tracheal intubation in the critically ill. And now this study, nice, well-powered, randomized controlled trial showing that a clear benefit definitely shows that we should adopt the video laryngoscopy in critically ill patients, and it should be used as a default whenever it is feasible. Now, this is another study in intensive care medicine that was showed, 999 patients, the randomized controlled trial from Samir Jaber, where they use a stellate during the first attempt at intubation versus not using a stellate. And this was done using direct laryngoscopy. And what they found, there was a significantly higher first pass success when a stylet was used during the first attempt at tracheal intubation. Now, we usually use a stylet when we encounter difficulty during the first attempt. We use it as a rescue, but here we use it in the first attempt. And when you talk about a bougie, this was a bougie, the trial that compared a bougie for tracheal intubation versus a stylet for tracheal intubation during the first attempt at tracheal intubation again. And here they found no difference between the two arms. Now, taken together, these studies actually show that in critically ill patients, we shouldn't use a bougie or a stylet as a rescue, but you should use it upfront during the first attempt at tracheal intubation. And this can significantly decrease the incidence of increase the incidence of first pass intubation success, unlike in the operating room where you often use it as a rescue. So going to post-intubation care, now I'll coming to the end of my presentation, one very important thing is the esophageal intubation during RSI. Now, if you have an esophageal intubation, unlike in the operating room, you put the tube in the esophagus, you remove your tube, you mask ventilate, it can often happen when you have a junior territory. In critically ill patients, even a single episode of esophageal intubation can result in severe hypoxia. You can look at this study. It's an old study that shows patients who had esophageal intubation versus not. And you can look at any of these complications, and there's significant difference between the patients who had or did not have an esophageal intubation. So an esophageal intubation is not well tolerated, and we should make every attempt to make sure that we rule out any esophageal intubation. And the important message is use capnography to exclude esophageal intubation. And I'm sure you may have seen this paper published in Anesthesia. And this is a group of 14 international airway experts called the Puma Group who's come out with it. I'm very proud to be a member of this group. And we've come out with guidelines on how to prevent unrecognized esophageal intubation. And this was following a lot of unfortunate cases in the UK and Australia where patients have died because of unrecognized esophageal intubation. And one of the key recommendations of that was to use, end-tidal CO2 for following every tracheal intubation, and to use a video laryngoscopy. There are many recommendations. I won't go through it, but these two are key to prevent missing an esophageal intubation. And this is a graphic from the paper, which I'd like to share with you, that whenever you do a tracheal intubation, this is the kind of end-tidal CO2 trace that you should look at. Do not just look at one trace, but look at 7 traces of consistent waveform capnography with no decline, because you can have a situation where you had a difficult intubation, a lot of air has gone into the stomach, and when the tube is in the esophagus, and you can get an end-tidal CO2 trace, but it'll start declining. So none of these are acceptable. You should have a trace where it's either ascending or you have consistent waveform capnography. Just to tell you the importance, because a lot of times people see one waveform and they say, okay, the tube is in, but we should wait for consistent waveform capnography with no glyph line. Now, interestingly, in the INTUBE study, as I mentioned, only 17% used video laryngoscopy. And interestingly, 60% of the patients were still using auscultation to confirm tracheal intubation. And waveform capnography is only used by 1 in 4, 25% of the patients, of the clinicians. And this is 10 years after the National Audit Project, which clearly showed increased morbidity and mortality due to not using capnography. So we have a long way to go. And this is not data from the developing world where you can say, okay, maybe capnography is not available. Even in the developed world, in the operating room, we always use capnography, but in the ICU, it is very underutilized. And we really have a long way to go to perform, make sure that waveform capnography is used. And with this, I will, conclude my presentation by giving the conclusions from what I presented. So first of all, most importantly, the physiologically difficult airway is one in which both pathophysiological and physiological alterations in the patient increase the risk of complications during tracheal intubation. We should be cognizant of this entity and not only think about anatomically difficult airway. And remember, hypotension is the number one complication, not hypoxia, but both these two taken together are the most common complication. INTUBE study has shown us a high risk of mortality at 28 days if you have intubation patient experiencing the complications. So we should prevent this. And the strategies outlined that in this presentation may help in safer management of these patients with a physiologically difficult airway and should be adopted. They're evidence-based, including the consensus recommendation from the expert panel. And most important to remember is that tracheal intubation is a life-saving procedure. And this life-saving procedure can actually turn into a life-threatening complication if it is not managed appropriately. I leave you with a graphic from our paper, and I urge you to really read the paper from Intensive Care Medicine published last month, because it summarizes the physiologically difficult airway and everything I've been talking about very nicely. And with that, I thank you very much for your attention. I'll stop sharing my slides so I can, and happy to take questions.
Well, thanks, Sheila, very much. And there's quite a few issues to discuss, in my opinion. And first of all, congratulations for this major contribution in the field and covering a lot of multi-center international studies. And there's one thing that what I'm missing from your consensus paper is invasive arterial pressure measurement before intubation. So your minimum required recommendation is non-invasive blood pressure measurement, but that is just no good. And I can understand the rationale that that possibly there is no time, there is no experience, but you request an expert standing at the head, so 2 persons for intubation, But I think having an arterial line and measuring blood pressure continuously is a very important safety prerequisite. And having a syringe with noradrenaline drawn up and attached to the patient, it is again something that secures that we can prevent collapse. And if we do that, then possibly propofol can also be a safe agent if you use it in very small doses and you titrate it to the patient's need.
Right. Very, very valid points. And thank you very much for bringing that up. And, you're absolutely right. Whenever there is an opportunity to put in an arterial line, and sometimes it may be an intubation in a patient who's not intubated in ICU and deteriorates and already has an arterial line, well, that's the ideal situation. You have beat-to-beat monitoring and, the arterial pressure trace. But that's not the situation often in patients who come where you have emergent tracheal intubation. So what we've recommended is at the least have this much monitoring. But of course, every opportunity should be, you should try your best to have an arterial line in, because that's real-time blood pressure monitoring. And we know that in patients in shock, non-invasive blood pressure monitoring is not very reliable. Now, coming to propofol, like you, I always, being an anesthesiologist, I don't like ketamine. Ketamine is a drug we threw out of the operating room many years ago. And I love to use propofol. It blunts the airway reflexes really well. But so my practice was that if I saw a patient in the ICU with a reasonably good blood pressure, I would give propofol. But if the blood pressure was low, they were in shock, I use ketamine and etomidate. But what the Intube study has shown is that irrespective of the starting blood pressure, and as I mentioned, the sympathetic drive often keeps the blood pressure up, this transition into hypotension, you use a propofol. And therefore, we have to be very cautious. Anesthesiologists don't like to get rid of propofol. They'll use ketofol, they'll mix two things, somehow they want to use the propofol. But really, we have to try to not treat with the norepinephrine, but rather prevent. Of course, we have to treat the hypotension, but we have to do every attempt now to prevent this 42%, because this is a very high incidence of complications. So every attempt, and one of the measures, which is something that can be avoided, is propofol. So by and large, as far as possible, unless it's an absolute elective intubation that's happening in the intensive care unit, we should try to avoid using propofol and use ketamine or etomidate for the tracheal intubation.
Yeah, I mean, I could go on this, but I want to stop this propofol story here. Yeah. But I entirely agree with you that hypotension is a serious issue. And we have data from Dan Sessler and Andrea Kurtz's group from the US that in the operating room, if irrespective of the time spent in hypotension, meaning less than 65 millimeters of mercury, let it be 1 or 10 minutes, the risk of developing major adverse cardiac events and acute kidney injury in the post-operative period increases like 7-8-fold.
Absolutely. So
do we have data, and excuse my ignorance if I don't remember, in the Intube study, did you look, apart from 28-day mortality, which is a very hard outcome, no doubt about that, but did you look into the myocardial injury, acute kidney injury, the incidence of these adverse events of hypotension?
No, unfortunately not. So this was a prospective observational study. So we didn't have the opportunity really, and we didn't expect a 42% hypotension. We were really thinking the hypoxia would be higher, and this was like really a surprise finding. But we did look at mortality, and it was, the first study that showed that this cardiovascular collapse is associated with increased mortality. Because a lot of times you have hypotension, you give a vasopressor, and you're fine. But if that is actually going to increase your mortality, then you really have to prevent this complication, not just treat it. So that was an important finding from the Intube study. But we don't have data for the other, we don't have data on,
Not even for organ support-free days?
No.
So the correlation between the length of organ support-free days and hypotension, no?
No, we don't.
That's a pity. Anyway, we have a question. What about the adrenal suppression after a single dose of etomidate? Should it be a default drug for rapid sequence induction despite this side effect?
Yeah. So adrenal insufficiency is always, something that people have been concerned with the use of etomidate. And there are case reports that have shown that even a single, use of etomidate has caused this. But this was initially a concern after the first randomized study was done, which was published in the Lancet more than 10 years ago. But the recent data, the studies, we have big studies now. Several randomized controlled trials have really not showed any difference in the complications. So I would say, using it one time transiently for intubation should be fine with etomidate. Though in India, we use a lot of ketamine. It's very cheap, readily available. And it's good news for us that even the Bayesian analysis shows a trend towards, lesser kind of mortality in these patients with the use of ketamine. But I would say that either drug, the consensus was that either of the experts were that either drug is okay unless contraindicated, but should be used as a default in critically ill patients. In fact, if you look at emergency department, the ED physicians, they use a lot of ketamine and etomidate. It's often the anesthesiologists who are using propofol, but they are using these drugs much more. Even the physicians who work in the intensive care unit tend to use ketamine and etomidate rather than use propofol.
Well, I have several questions on my mind. One is gentle mask ventilation. You quoted that article, that randomized control. So was the gentle mask ventilation performed by a self-inflating bag? We call it ambu bag, or was it done with a water circuit or a Maples-on-Sea system? Do you remember?
No, but this was a study from United States, so it was done by the Ambu bag. But of course, if you're in the UK, you use the circuit, the very popular circuit that is used. It's very UK specific. It's not used across the world. But again, if you look at it, classic RSI, no mask ventilation, you're always worried about aspiration. But look at these patients; they are at such a high risk of desaturation. So that was the logic behind doing this. I would say when you say gentle, then you say how gentle. It's very careful mask ventilation in those patients who are not at a very high risk. For instance, someone's had a full meal and come, I'm not going to do mask ventilation that patient. But otherwise, when there's a huge risk of this patient desaturating versus a perceived risk of aspiration, it's better to give that gentle mask ventilation because that hypoxia, bradycardia can also transition to cardiac arrest, and you have to be cognizant that that risk is also higher than the perceived risk of aspiration. So it's a fine balance that you have to draw, and that's what that NEJM paper has taught us.
Thank you. I can't see any further questions, and we are really running out of time. So I would like to thank you, especially Sheila, for joining us, and thank you very much for taking your time. It's 8:30 in the evening in Mumbai at this time, so a special thanks to you for joining. Mind you, Robert Roberts joined in at midnight from Australia for this Sip of Science event, so you are only on the second spot in this regard, right? but we are grateful for you.
My pleasure. I would come at any time for this program for you. Thank you for the kind information. And
thank you very much. And a special thanks to Semmelweis University and Translational Medicine, which hosts this meeting and supports, and especially to Attila for doing all the technical workup. So the presentation will be available on YouTube. We will circulate the link to all of you who attended and those in the so-called Mentor Halo link. So, and with this, I close the session. Thanks again. Thanks, everyone. Have a nice evening. Bye-bye.
Thanks, everyone. Thank you. Thank you for
Bye-bye.